Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome back, it's been a while, but Gigi Pierce. You are a nurse and you're the Nurse Care Coordinator at TidalHealth, and you are here today to talk about a very important topic, that of advanced directives.
Yeah.
So thanks again for coming in today.
Thanks for having me.
Aren't we in a month that's, I wouldn't say celebrates, but is promoting the importance of completing advanced directives? And of course, one of my first questions to you is, why is it so important to get your advanced directives in order?
Okay, so your advanced directives or living will are just documents that everyone should have, and maybe not everyone does. So they just highlight in April the importance of just Healthcare Decisions Day, basically, and just to remind people that it is important. It's like almost like an insurance policy that you may or may not ever use, but it's always good to have, or it's really important to have, especially if you don't have one and you run into issues where you're in the hospital and you're on life support, or you've had a major stroke or a car accident or something terrible has happened. That's when you need it, and that's when we find out that most people don't have them.
Well, every state has different forms, and every state has different rules about who makes decisions if by some chance you cannot speak for yourself and or don't have advanced directives in writing. And this is totally separate from a will about your possessions, but there's
Correct.
two types of advanced directives, so let's maybe talk about each one of those, starting with the living will.
Okay, so the living will is part of the advanced directives where you list whether or not you would want to be on life support, feeding tubes, and really kept alive with feeding tubes is basically the premise of the living will.
And of course, a feeding tube means if you can't swallow anymore and they put a tube in to give you liquid nutrition.
Right.
And in many cases in medical care, feeding tubes are not recommended, at end of life or in people that, say, have end-stage Alzheimer's.
Correct.
But in some cases, you should make that clear when you would want a feeding tube or not. You have a way to say it both ways.
Exactly. And we as healthcare providers, we really want to do what you would want us to do, but if we don't know, we opt for we go for the gusto. I mean, we will do everything possible to keep someone alive just because we don't know. And if the family doesn't know, that's kind of, we err on the side of doing more, even if someone wouldn't want that. And it's a shame to do things to folks to keep them alive if they really didn't want that to happen.
Yeah, and other things would be like the CPR. Do you want CPR? Do you want to be put on a ventilator in the event of, some kind of catastrophic health event? So the living will, though, isn't it a little more restricted in terms of you have to put certain scenarios? There's a specific form you can download, right, from a website? I know you're going to give us all this information at the end of where people can get these forms that work in the state of Maryland or Delaware.
Mm-hmm. Yeah, each state has their own healthcare forms, advanced directive forms online, and you can download them for free. There's also the 5 Wishes organization where you can purchase, it's about $5 to purchase a packet of their advanced directives, a little more easily to understand, and they have a little bit more questions that are maybe more for people who are lay people and not medical. The forms from the Maryland state, I know, are very legal jargon-ish.
A little technical.
Yeah, they're a little technical. They're not easily understood. That's why it's always nice to have somebody who knows how to fill these forms out, go to them to help you fill them out and to maybe ask questions. And we do have that service through TidalHealth with our chaplains, spiritual care department, the case management department, social work. I myself can meet with people, and we do webinars once a month. We can also come to places to do workshops. We've done that at the MAC Center and the Cancer Center, and have people come and they bring their experiences and their their questions and then their forms. If they want help to fill them out, we do that as well. We're going to try to have that in the future, more workshops in person, which I think is really helpful, because then other people get to tell us about their experiences with end of life, and whether it's their partners or their parents or other loved ones, where things went the way they wanted them to, or they didn't, and then they have experience to go by to make their own decisions for themselves.
Right, because most states have an order of succession. If there's no advance directive, then you go to the spouse. If no spouse, you go to the children. And unfortunately, when child is plural, there can be disagreement.
That's what you want to
And
avoid.
it can lead to some issues.
Yeah, and you don't want to leave these decisions up to multiple children who have different ideas about what you should do, and you have different experiences and relationships with these children, and it does cause a lot of stress and strife in their life to have to bear the burden to make these decisions, especially if you didn't tell them what your wishes were. I know that my mom is a nurse, my grandmother was a nurse, we have a lot of nurses in our family, so we've always kind of talked about situations like this, and we absolutely know what each other would want in certain situations, so that's always good, but not all families are openly able to speak about end of life, so it's important to respect that. If they don't want to, that's fine. I just always feel like more information about anything, you can make a better decision if you know more.
Well, it's definitely an uncomfortable topic for most, but it is something that I know I strongly feel, as you do, I know as a nurse, autonomy, respecting one's autonomy to decide what they want done or not done. And that should be respected at all costs. But if you don't write it down, then that's where it can lead to maybe your wishes not being followed.
Yes. Oh, and one point that some people do, if you have an estate and you have an estate plan, you have a will, a financial will. Usually part of that will done with an attorney, you do get your advance directives done in that will. So keep in mind that if you have met with an attorney about your estate, more than likely you have a living will, a medical power of attorney embedded in that. But just get a copy of that, because usually that's put away in a bank or a safety deposit box, and you want the medical part to be given to your provider, your primary care provider, or the local hospital that you're going to go to, and keep that aside so that's accessible to the family members, because if you need that form, you're usually not able to go get it.
Right. And then on the other side of the coin, you don't need an attorney to fill out an advance directive. You can get those forms from the website and fill it out yourself.
Absolutely, yep. Or get them from your primary care provider.
Right, that's true. Most providers do have them available. Mm-hmm. I mean, it's not that hard to do. It's just you have to have the wherewithal to say it's time to make these decisions and put them down on a piece of paper so that my wishes are followed.
Exactly.
So we talked about the living will. So the other way to implement an advance directive is called the durable medical power of attorney. Sometimes it's called healthcare proxy. So tell us about that. Right,
and that is on the Maryland State Form. That is the first part of the advance directive, and you are going to choose someone who is willing and able and who knows your wishes. And that person is going to be your proxy if you can't speak for yourself. And that is the only way that this document comes into play, is if you are unable to speak for yourself. Otherwise, this document just is dormant. You don't need to use it for anything. But your medical proxy is the person who you're going to list as your decision maker when in fact or if you ever become unable to speak for yourself. And then you want to pick somebody who can uphold your values and abide by your wishes, and who's really emotionally able to handle a tough situation, because usually it's a pretty stressful situation if they do need to come into using this form.
And then one of the common areas would be, say someone's had a stroke and is in a coma, or someone has end-stage Alzheimer's and they're declared incompetent or are incompetent, not able to speak as to what they want or don't want. There's certain situations it's really important to have all that specified. And with the durable medical power of attorney, it does assume that you are going to talk to that person and make sure they're aware of all the different scenarios. And do I want to be intubated? You know, put a tube down to breathe. Do I want CPR? Do I want a tube feeding? But it is the best way to go. And you mentioned a trusted person, and you should have a backup, correct?
And you should have a backup. Yeah, it is important because sometimes you're doing these forms like I've done my forms in my 40s, and you know, and if I live to be 90, you know, my medical power of attorney may precede me in death. So you want to have a second person. And then, of course, I have helped other people with their advanced directives. And one woman was, she said her spouse passed away, her best friend passed away. She really didn't have anybody to list as her medical power of attorney. She didn't just want to put any friend, but she what she did was she left that blank. She didn't pick a medical power of attorney. She just filled out her living will so that her providers at the time will know exactly what to do. So you can do parts of this document that, you know, whatever works for you personally.
Yeah, as long as you get something done. I think that's more important.
It is.
And it's a tough thing to do, but encouraging people that, number one, you may not get your wishes followed, and number two, it can create a good bit of stress and family conflict if you just leave it open and people start arguing. She would have wanted this. No, she would have wanted that. And as nurses, we've seen this situation.
Yeah.
So
Yeah, very much so.
I know you also wanted to mention that once you make an advanced directive, you can update it.
Correct.
It's
yes.
not set in stone forever. You can go back in and say, wait a minute, I've changed my mind, and update it, and that will be the most current document that's to be followed, correct?
Correct. And you're basically making a decision in the Maryland form. You're making a decision if you wanted to be kept alive with tube feedings, if you're in a persistent vegetative state, an end-stage condition, or terminal condition. And it only comes into play if you're deemed to be in one of those situations. That's the only time the living will comes into play. But there's another form that is part of advanced care planning, and it is called a MOLST form, a medical order of life-sustaining treatments, which is very important if you have a life-limiting illness or a chronic disease, or you're elderly and frail. Usually that's the reasons why you would want to consider a MOLST. And it's if you want to limit things like CPR, ventilator, feeding tubes, dialysis, whether or not you would want to go to, say, University of Maryland or Johns Hopkins or another facility for a higher level of care if we couldn't do it locally. You can choose whether or not you'd want to do something like that.
And is that the one you keep on the refrigerator in case paramedics or, you have an event and EMTs or whatever come to the home and they look on the fridge to see if that form is there? Because
Yes.
that can be very helpful in determining whether they take you somewhere or not, or whatever the case may be.
Right. And your family, your caregivers should really very much so know those wishes if you wanted to limit CPR and ventilator and, all the things that a full code would encompass, which can be very painful and not necessarily helpful in some situations. And we do it automatically unless we're told ahead of time that this person has decided to not have CPR and all that entails for a code blue is what they call it.
Well, I know there's many providers that will initiate the conversation, particularly as someone gets older and starts thinking more about, chronic illness, something could happen. But also people have to advocate for themselves, correct? And
Correct.
perhaps talk to their provider about it.
Right. They can. You can set up a separate appointment to just do advanced directives with your primary care provider, which I encourage, because you can set the time aside where they don't have to deal with other issues that they're dealing with, and talk to them. Get your questions answered about life support, whether or not you would want it, whether it's appropriate, the pros and cons, the chances of recovery. Whatever questions you might have.
So either way, it's important to have the conversation, correct?
Correct.
With
yeah.
either your family or your significant other spouse. your provider, you know, just start talking about it. And I know they say you should have, everyone should have an advance directive, but I know a lot of young people don't feel it's necessary. So it's usually when you get into maybe your 40s or 50s, you start
thinking about
it a little more. And for some people, it's just part of the will. And then for others, you would have to make your own document, you know, obtain the form and so forth.
Exactly. But these documents came into being based on two young women who, you know, who wound up in comas for many, many years, and they wound up in nursing homes with feeding tubes, and the family were in strife over whether or not, you know, their loved one wanted to be kept alive in a nursing home. And they went to the Supreme Court, and so that's Karen Ann Quinlan
yeah.
and Terry Schiavo.
Right.
So, you know, that's why it does happen to young people sometimes. And we didn't know what those young women wanted because, you know, they didn't either have the conversations or the paperwork. And but that was in the 70s. And,
right, I know
and
that's a long time ago.
We're still trying to get people to fill out these forms.
Well, they passed some laws in the early 1990s to, where healthcare providers or hospitals and such have to ask you if you have it or not. But of course, if the answer is no, that should be an impetus to say, let's talk about getting that in order, because I think the rate for advanced directive completion is still around 20 or 25%.
Right.
It's still pretty low. Even with all this education and emphasis and laws about it, that you have to be asked before you go to a nursing home or hospital.
Yeah.
We still have a long way to go.
We do. It's okay.
That's one reason I wanted to have you here was to remind people of how important it is.
Yeah. And I, you know, my first job as a nursing student, I worked at the nursing home locally, and there were lots of patients who were, they were called total care, where you would have to turn them every 2 hours and change them and clean them, and they had the feeding tubes, and it stuck in my mind, like, I wonder why there's so many people like that in this nursing home. And then later on, you know, I realized they had strokes and they had lots of health problems, but they didn't have advanced directives. That was why that they were in the nursing home with the feeding tubes. Is we automatically put people in nursing homes with feeding tubes because we just didn't know that they didn't want that. So it'd be nice to be able to preemptively make those decisions known to your family members so that doesn't happen to you if you don't want it to happen to you.
And there's so much evidence now, research evidence since, on when it's appropriate to do a feeding tube and when the complications outweigh whatever benefits they have. And the same with CPR. When you get to a certain age with CPR, it does more harm than good in many cases and has little benefit when you get to a certain age. And I'm talking 80s, 90s.
Yeah.
So it's important that we use the most current evidence to guide decision making.
Right. And I always say if you don't want to be a do not resuscitate or you choose to have CPR, even if you are elderly and frail, make a plan for what happens after that, because chances are you may not be able to be the same person you were before that happens, because usually you have more health problems afterwards. And you may not be able to go home again. More than likely, the literature shows that if you've had CPR and you're elderly and frail, you're probably going to wind up in a nursing home or long-term care facility just because you need so much care afterwards.
And I do hear more people talking about quality of life, you know, living better. You know, is it going to affect how well you lead your life, or is it just about living longer in a compromised state? So at least people are having conversations about that more.
Yeah, quality of life is a big deal. Yeah.
I know you brought some books. Do you want to show us some books that people might be interested in?
Sure.
Reading on the topic?
B.J. Miller wrote. He's got some really good. He's got a great book. It's The Beginner's Guide to the End: Practical Advice for Living Life and Facing Death. He's got a TED Talk, and he also has a website. TidalHealth is his website, and he does also offer online advice for end-of-life planning. Of course, you probably have to pay for it, but just know that it's
there's a lot of free talks
resources
out there on YouTube, as you mentioned, and TED Talks and such. And the other one is?
How We Die, written by a physician, and it's just reflections on life's final chapter. It was just really good about, you know, just end of life and questions that people have, and it's from a doctor's perspective. And Atul Gawande also
Right.
wrote that book,
Being Mortal.
Being Mortal.
Highly recommend it. It's one of my favorites. It really delves into certain scenarios, and it's even a younger woman who's pregnant but has terminal
Yes.
cancer, and all these decisions, you have to weigh,
Yeah.
quality, quantity, and when do we get to a point where the care that we're giving is no longer achieving anything, fetal
Right.
care per se. And,
Right.
and that's when it's tough decisions for families, but the more you know, being educated.
Yeah, and you have
On
to
the topic.
weigh your pros and cons for any decision that you make, and we plan for births, and we plan for weddings and retirements and birthday parties and wedding. I mean, we plan for everything. This is another thing that we need to plan for because it's going to happen. It's just a matter of how and when, and how comfortable and comforting do you want that end of life to be, as opposed to a lot of stress and strife and difficulties.
Well, dying peacefully at home is what many people strive for, but unfortunately, unless you have advanced directives, you may automatically end up in the hospital. And
Correct. And it's
it
harder
depends on what you want.
it's harder to take someone off life support than it is to just decide ahead of time not to start. Emotionally, it's harder to pull the plug, they say. So if you can go in with a plan ahead of time.
No CPR, no ventilator, no
Yeah.
intubation. And if that's what you want.
If that's what you
I don't
want.
want anybody to think that, I never would think that's the right thing. It's
Right.
an individual's choice. But you're right, it's better to say it up front, because once it happens, it's hard to take it back.
It just feels very much harder. So that is the case. And yeah.
Well, thank you for coming in to talk about this important, but it is a challenging topic to discuss. But as nurses, oftentimes, we're charged with the responsibility of being more comfortable with having these difficult conversations, but they are necessary.
Yeah, and it's nice to be able to offer our experience as healthcare providers, and just as people ourselves. We're going through the same things with our parents and grandparents, and use our experiences to help others make the best decision for them.
Very good. Well, thanks again, Gigi, for coming on today with such great information. And I know you have some websites where people can get these forms and more information about advanced directives. So we'll post that at the end of the program.
Okay.
So thanks again.
Thank you.
And thank you for joining us for this edition of Focus on Health here on PAC 14.